This is a presentation of middle-range caring theory. In the past, we've studied grand nursing theories related to caring, such as Lenicher, Watson. This week, we'll do some reading about Boykin and Schoenhofer. And I know that many of you are familiar with caring theory, especially in relation to Watson, due to the broad adoption of this by health medical systems. However, this presentation will review middle-range caring theories from Duffy Caring Model and Swanson's caring theory. So let's start off with Joanne Duffy's quality caring model. I hope that at the end of reading this chapter, you'll understand how the model was developed, the role that nursing plays in quality care provision, and ways that we can intervene with caring-based interventions, the importance of these caring relationships in nursing, and that we can describe Duffy's term, feeling cared for, explain recent changes in the model from a linear model to a more simultaneous model, and explain how the model is being used in nursing practice and research. Joanne Duffy was a nurse theorist from the East Coast. She was a professor at Indiana University School of Nursing. She developed much of her theory while at George Washington University Medical Center, and she worked in the Transplant Center and cardiovascular nursing. So she first examined this link between caring behaviors and patient outcomes. Then she developed a caring assessment tool called the CAT. And she was interested in the hidden value of nursing work. As many of you know, in the late 80s, there became quite a bit of pressure on nursing to indicate what value they were adding to hospital system care. And it was difficult for RNs to quantify the care that they were giving, and in a way that administrators could understand the value of what was being provided. So this quality caring model was developed to guide both practice and research, and also to examine nursing interventions to improve this feeling of being cared, because patients have perceptions that nurses just don't seem to care. The model's been revised twice, and it now is more generally adapted to multiple care areas. So perhaps it's moving towards a grand theory, but the link between caring relations and quality care is even more explicit. And this is essential for being able to respond to the demands of the nursing profession, especially today in an age of cost containment. At the time this was developed, there were a few nursing theories that could that guided caring-based interventions and looked at nursing caring as a measure of quality in hospital institutions. So it was initially tested with patients with heart failure. These caring relationships were one of the core concepts. The problem was that this is hidden in daily work of nursing. We don't document our caring interactions. We document the medications we've administered, the procedures we've done. And so it tends to be hidden, and it's different from caring about relatives and friends. Nursing caring is a very intentional, skillful act that is not captured in most metrics in hospitals. So it requires specialized knowledge, attitudes, and behaviors. These are the KSAs, right? Knowledge, skills, and attitudes in order to perform nurse caring. It helps a patient feel cared for. It frees recipients to do these things. This would be, in essence, an assumption that it frees recipients to take risks, learn new healthy behaviors, and participate in evidence-based decisions. When you're feeling cared for, it influences patient outcomes, and these have to do with the area of knowledge, safety, comfort versus anxiety, adherence versus human dignity, and health and satisfaction. So the purpose of the model is to guide practice and described the linkages between quality of care and human caring. And this was the foundation of this model, was used in nursing research. The middle range theory views quality as dynamic, nonlinear, and enhanced by caring relationships. So when we think about this in relation to worldviews, originally this theory would have been considered more mechanistic, but as the theory developed and the ideas and our worlds changed, it went from a reaction worldview to a reciprocal interaction worldview when we think about that component of our course content. Here's some of the main concepts, and you will recognize the meta paradigms here, that humans are in relationship. Here's some beliefs about humans in this, that we're unique, multidimensional beings. We're both different and the same. We're social, and we mature, we form communities, and we advance through human connectedness. Other concepts are that relationship-centered professional encounters. So these are independent between the nurse and patient family. They're also collaborative between nurses and members of the healthcare team. And the outcome for these professional encounters are that people should feel cared for. It's a nurse-sensitive and positive emotion that people have about their interaction with the nurse. It signifies to patients and families that they matter. So if people feel cared for, that is one of the results of this outcome. And it allows them to relax, feel secure, and they have to feel cared for. In other words, it's an antecedent before you can have a quality health outcome. So it's basically saying if people don't feel cared for, then they cannot have a quality outcome. Another concept is self-advancing systems. So this is a phenomenon that emerges gradually over time and enhances systems well-being. So if we think about the systems theory that we looked at, Duffy's theory of quality caring fits nicely into the systems theory. In this case, caring relationships basically propel the system in a forward movement and emerge over time due to multiple caring connections that a person makes in the healthcare system. So here's those assumptions about humans, assumptions about caring. We could almost call that the nursing meta paradigm, right? Embedded in the daily work of nursing, it's tangible, done in a relationship. All of these are assumptions of Duffy's theory. Here's some more. These have to do with the caring relationship. So you notice now we don't, this could be considered an environment. They benefit the carer and the one being cared for, society, professional nursing work, and then feeling cared for is a positive emotion, and that could be considered health. So we're looking at the location where caring happens. So these could be human, nurse, and then environment, and then health. So we see, although these are not identified with those meta paradigms of nursing we've studied, they're closely related assumptions. And this is why this is a middle range theory instead of a grand theory. If this caring was described as nursing is, if caring relationships were described as an environment, and if feeling cared for was described as health, then this could be a grand theory. But because they're described more distinctly, this is why this is a middle range theory and not a grand theory. Let's talk about propositions. Propositions are the relationships between the different variables. So the first one is human caring capacity can be developed. That is saying that the human caring capacity, which is basically what the RN does, can be increased. Caring relationships, remember that is somewhat of our environmental component. They are composed of processor factors that can be observed, and they require intentional action to occur. Engagement in communities through caring relationships enhances self-care. And remember, we were looking at that from a systems perspective. So this examines that healthcare system, and that independent caring relationship between patients and nurses influence the feeling cared for. So basically, that relationship has an outcome of feeling cared for or not feeling cared for. And that is what a proposition is, because it's relating these different concepts and how they increase or decrease. Collaborative caring also can influence feeling cared for among team members. How often do we think of our call to the lab or to X-ray as being something that can influence feelings of being cared for those individuals? Imagine how our communication with others and the improvement of that can benefit a whole health system. So caring relationships facilitate growth and change, and feeling cared for is the antecedent to self-advancing systems. That means that outcome actually advances both the individual and the system. When we look at the terminal and both the terminal, which is the long-term health outcome, and the immediate health outcome. Self-advancement isn't linear. Anyone who's worked with folks with diabetes like I have knows that advancing your self-care management is complex. It can move forward and backwards, and self-advancing systems need to be self-caring or self-healing, or they basically don't advance, right? They go back and forth. So caring relationships can contribute to individual, group, and system. So if you can think of that patient, interprofessional healthcare, and the healthcare system. So there are benefits for quality in all of those locations. Let's look at the role of the nurse in this theory. Some of these are a bit repetitive, but the RN needs to attain knowledge and expertise in caring. They need to initiate caring relationships with families, with other nurses, and with all the healthcare team. They have to maintain an ongoing awareness of that patient-centered care, that patient point of view. And then they have to take self-caring activities for professional and personal development specific to evidence-based practice, and being involved in practice-based research and learning. So that expertise is embedded in nursing, and our participation in that occurs both in our employment and also in the broader community. We contribute to knowledge of caring and the profession using all forms of knowing. And now you understand those forms of knowing from your work with CARPR, and they maintain an open and flexible approach. The RN can use measures of caring, which of course Duffy suggests the CAT, to evaluate nursing care. Caring relationships occur with yourself, with patients and families. They're collaborative with other healthcare members, and they also involve the broader community. Here's some caring factors. Multiple problem solving, attentive reassurance, human respect, encouraging manner, healing environment, appreciation of unique meaning, affiliation needs, and basic human needs. So this goes much beyond Maslow, doesn't it? And works with the entire pyramid. Caring factors are used in relationship with others and comprise the basis for the knowledge and skills that are required to practice with a quality caring model. Let's apply these to practice. These have been applied in research. So if you look up Duffy, you will find all kinds of applications and publications related to using the quality caring model for both health professionals, educators, leaders. So this helps. You'll see in all of these publications the importance of the interdependence for advancement of quality healthcare. Many systems are using this quality caring model. So when you see that, just like you see Watson, you can see it as a foundation for patient-centered care. They look at improving professional workflow. It can guide collective relationships, because often our inability to relate well in the interprofessional health team can impact the quality outcome for our patients. And it also balances this challenge between doing and being. And this has to do with doing for and just being with. And we'll look some at those elements of caring with our next theorist. But right now, this again is that revised caring assessment tool. There's 27 items. And so this could be a tool if you decide to examine caring with your MSN project or teach some aspect of caring. You could try using this tool. And then there was one that has to do for administration, how nurses perceive nurse managers. So this is another area of assessment that can be used for practice and importance. And then these concepts, assumptions, and propositions, which are all components of theory, can be the basis for research. And I know many of you are still working to understand what propositions are. So here's an example. Feeling cared for, which remember is one of the outcomes of the quality caring model, influences the attainment of intermediate and terminal health outcomes. So you could test this with research by linking the results of an instrument measuring caring with a set of specific patient outcomes, such as in the case of this congestive heart failure, you could link it with readmission rates and other outcome for CHF management. Here's references. I just want to show you some of these because I can teach you a little bit about APA style for a moment. This one right here is showing the caring assessment tool because it's a proper noun. It's capitalized. And here we have the book title is in sentence case and also in italics. Notice the first initial, Watson's first initial was is placed before the last name, and I just noticed this colon should not be there. That must have been an older edition. Here we have an ampersand before the fourth author. The first word after the colon is capitalized, and there is both are in, this is in sentence case, this is in title case because it's the title of a journal, and 30 is the volume number, it's in italics, the issue number is not. So I just wanted to show you some of those references and that example to help you as you continue to work on your APA style. Now let's talk briefly about Kristin Swanson's theory of caring. You are going to be able to see where she came from because so many times the theories that are developed have to do with the place and time that the author of the theory is in. And as we think about this theory of caring, it was originally a middle range theory that was primarily used with 5 caring processes. And I think when you will really identify with Swanson's definition of caring and these caring processes and see that although it was originally developed with women who'd experienced a miscarriage, these caring processes could be applied in multiple areas. So this is the study of, this was developed in response to a miscarriage and the framework of caring to have a therapeutic clinical exchange. So she developed this during her doctoral study and the miscarriage caring project that she did, and it was also then used in the neonatal intensive care and refined with high-risk mothers. So this is how this came, and this is how she began thinking about the study. What's wrong? What can be done? What's right? How can that be strengthened? What's real? And for people experiencing a specific health problem, and how can we measure the impact of caring interventions for specific health problems? Notice it's the specificity that makes this a middle range theory. Here's a quote, and notice the APA style is Swanson, the year and the page number, because it's a direct quote with the period after the citation. So caring is a nurturing way of relating to a valued other toward whom one feels a personal sense of commitment. I define caring as a nurturing way of relating to a valued other toward whom one feels a personal sense of commitment and responsibility. Here's her caring processes: knowing, being with, doing for, enabling, and maintaining belief. Knowing, striving to understand when an event as it has meaning in the life of the other involves avoiding assumptions, focuses on the one cared for, seeking cues, assessing thoroughly, and engaging the self of both the one caring and the one cared for. Being with, being emotionally present to the other. It includes being there, conveying availability, and sharing feelings while not burdening the one cared for. Doing for the other what he or she would do for himself or herself, if it were at all possible. Therapeutic acts of doing for include anticipating needs, comforting, performing competently and skillfully, and protecting the other while preserving their dignity. Enabling, facilitating the other's passage through life transitions and unfamiliar events. It involves focusing on the event, informing, explaining, supporting, allowing, and validating feelings, generating alternatives, thinking things through, and giving feedback. So this is not the enabling that we think of in a negative term, which enables poor behavior or unhealthy acts, but it is a facilitator in a supportive way. Maintaining belief, sustaining faith in the other's capacity to get through an event or transition and face a future with meaning. This means believing in the other, holding them in esteem, maintaining a hope-filled attitude, offering realistic optimism. That's important that we don't give false reassurance, but helping the person to find meaning, their own meaning in an event, and going the distance by standing by them no matter how their situation may unfold. So this Miscarriage Caring Project provided evidence that although the time had a healing effect on women after miscarrying, caring did make a difference in the amount of anger, depression, and disturbed mood that women experience after a miscarriage. The study was unique because it employed clinical research model, and its strengths were that it was intervention based on empirically derived understanding of what it is like to miscarry and on the conscientious attempt to enact caring and counseling women through their loss. So notice that these were empirical indicators of caring. And this led to more intervention studies, data gathering, and found that women felt heard, understood, and attended to in a non-judgmental fashion, and transformed techniques of gathering data into a caring intervention. So there was a meta-analysis. So that means examining many studies that clarified what caring meant so that this theory could be validated and generalized to other settings beyond the care of women with miscarriage. And these, again, are the references, and they're in APA style. And I hope that you find Swanson's theory of caring very accessible to you in your practice of nursing. I believe that this theory would be very beneficial, perhaps more so because of the everyday language of the theory. I believe it could be very helpful in nursing education as we teach students how to be with, know, and care for the people that they are responsible for in the clinical setting. So thanks for listening, And I hope that you find this rapid review of these two middle range theories beneficial in your practice and in your annotating of articles.